The 12-lead electrocardiogram is a precise measurement of invisible spatial geometry. It tracks electrical vectors as they move through three-dimensional space, providing a high-resolution map of cardiac function. The signal begins at the cellular level. For each cardiac cycle, the sinoatrial node in the right atrium fires, initiating an explosive wave of electrical depolarization that spreads through the muscle fibers. This electrical wave hits a deliberate physiological checkpoint at the atrioventricular node, briefly delaying the signal so the atria can finish contracting. From that node, the depolarization wave accelerates rapidly down specialized conduction tissue called the bundle of His, before dividing into the Purkinje fibers and spreading out through the massive ventricular walls. The central challenge of clinical cardiology is reconstructing this dynamic three-dimensional electrical sequence using nothing but a flat two-dimensional paper grid. To interpret these results, we must translate these flat, rhythmic traces back into the actual physical events occurring within the heart muscle. Tracking these physical events starts with the horizontal axis. As electrical voltage moves through the tissue, the sheer amount of contracting muscle dictates the size of the signal recorded. Look at this diagram outlining a single heartbeat. That first small bump is the P wave, representing the contraction of the relatively small atrial muscle mass. The massive deflection immediately following it is the QRS complex, mapping the depolarization of the heavy, dense ventricular mass. Finally, the T wave represents the recovery phase, bringing the ventricles back to their resting state. This graph shows how we track these events over time. The horizontal x-axis measures duration. One small square equals exactly 40 milliseconds, making one large square equal to 200 milliseconds. This math works because the machine is calibrated to pull the paper at a strict, continuous velocity of exactly 25 millimeters per second. Because the paper moves at that fixed speed, the heart rate can be determined by counting the large squares between R waves. One square is 300 beats per minute, two is 150, then 100, 75, 60, and 50. This temporal map also gives us the PR interval. Measured from the start of the P wave to the start of the QRS, this interval correlates to the time taken for the signal to navigate that physical delay at the AV node. A healthy heart completes the QRS complex tightly within 120 milliseconds. A wide, prolonged QRS complex spreading out across the paper indicates a physical slowing or a roadblock inside the heart's conduction tissue. The physics of vector directionality dictate that when a wave of depolarization spreads toward a recording lead, the trace moves upward. When the wave spreads away, the trace moves downward. This simple mechanical rule explains why certain leads generate deep downward deflections. If the depolarization wave moves at a right angle to the lead, the upward R wave and downward S wave will equal each other, creating an equiphasic shape. These directions are mapped by attaching electrodes to the patient's limbs. This creates a vertical plane slicing through the torso, giving us 6 distinct angles: leads I, 2, 3, VR, VL, and VF, all pointing inward toward the heart. By observing which leads show positive deflections and which show negative, we calculate the cardiac axis, the single dominant directional vector of ventricular depolarization. In a healthy heart, this collective wave spreads diagonally from top right to bottom left, tracking from 11 o'clock to 5 o'clock. If the right ventricle hypertrophies, its added muscle mass exerts more electrical gravity. The central vector swings hard to the right. Lead I becomes negative, and lead 3 becomes strongly positive, pointing to right-sided strain or a pulmonary embolism. Conversely, if a defect blocks the normal conduction pathway on the left side, the vector swings up and to the left, creating a deeply negative deflection in lead 3. Axis deviation acts as a mathematical compass needle, pointing directly toward overgrown muscle walls or electrical blockages deep within the myocardium. The limb leads provide a vertical silhouette. Completing the 3D model requires looking at the heart horizontally, cutting a transverse slice through the chest. 6 chest electrodes record this view. These leads, V1 through V6, are mapped sequentially across the right ventricle, over the central septum, and around the lateral wall of the left ventricle. 2 distinct physical forces shape this horizontal trace. The first is the central septum, which depolarizes from left to right. The second is the massive electrical gravity of the left ventricular wall, which outweighs the thinner right side. Positioned over the right ventricle, lead V1 sees the initial septal voltage move slightly toward it, creating a small upward R wave. But as the massive left ventricle fires, it pulls the dominant electrical vector entirely away from V1, creating a deep downward S wave. Lead V6 on the left lateral wall records the inverse. It sees the initial septal charge move away as a tiny downward Q wave, followed by a massive upward R wave as the thick left ventricular wall fires toward it. As you move across the chest leads, the trace morphs. Usually around V3 or V4, the R and S waves equalize. This is the transition point, mapping the exact anatomical location of the interventricular septum. If the right ventricle enlarges, it expands across the chest, and the transition point shifts out toward V5 or V6. The trace provides evidence that the heart has rotated clockwise inside the ribcage. Accurate mapping requires a flawless mechanical interface. The chest electrodes demand exact anatomical placement along specific intercostal spaces to map the horizontal plane precisely. Minor operator error distorts the vector map. Inaccurate placement or poor contact of the chest electrodes across the ribcage immediately alters the horizontal signals, generating distorted traces and artifacts that signify mechanical error rather than pathology. Voltage calibration controls the amplitude of the signal. A standard machine sets 1 millivolt of signal to trace exactly 1 centimeter of vertical height. If the setting is wrong, an over-calibrated machine will draw massive vertical complexes that can be easily misdiagnosed as severe left ventricular hypertrophy. Altering the paper speed stretches or compresses the timeline. Running at 50 millimeters per second widens the QRS and makes the heart rate appear slow, while slowing the paper down artificially compresses the perceived rhythm. Physical impedance also affects the trace. Skin acts as a resistor. Poor contact from sweat or hair blocks the voltage, causing erratic traces. The electrodes detect any ambient voltage. Environmental alternating current from motorized beds or electric lights will inject a thick, oscillating baseline interference over the cardiac signal. The machine detects any contracting muscle. If a patient is shivering, rapid skeletal muscle firing floods the recording with chaotic spikes that obliterate cardiac data. The machine records all detected voltage. The clinician must separate mechanical and biological noise to isolate the physiological truth. To evaluate that truth reliably, we follow a sequential algorithm on every trace. First, identify the rhythm. Second, measure the conduction intervals. Third, calculate the axis. Fourth, describe the QRS complexes. And fifth, examine the ST segments and T waves. Evaluating these parameters reveals that the healthy heart operates on a spectrum. Minor variations, like a small U wave following repolarization, are common physiological variants. Reliable diagnosis depends on understanding the underlying vector physics. Recognizing the mechanical vulnerabilities of the machine prevents the dangerous error of treating a mechanical artifact instead of a patient. Calculating vectors, verifying conduction velocity, and checking mechanical calibration provides a direct window into the living, three-dimensional geometry of the heart.